Hello everyone and welcome to another video from MedTube on metabolic acidosis. Metabolic acidosis is defined as a pathological process resulting in increased hydrogen ions concentration and decreased bicarbonate ions concentration. In other words, it doesn't necessarily mean that you have a decreased pH, because sometimes you have a normal pH or even high, and that's because of the ongoing respiratory compensation and or the presence of a mixed acid-base disturbance such as a simultaneous primary metabolic acidosis and the primary respiratory alkalosis. Now there are three main pathophysiologies by which metabolic acidosis occurs, and the first is increased acid production, which gives the hydrogen ions of course, and the second is decreased acid excretion, and the third is free losses of bicarbonate. And clinically we can classify metabolic acidosis into either a high anion gap metabolic acidosis or a normal anion gap metabolic acidosis. And the concept of the anion gap is actually quite interesting, so let's have a look quickly at what anion gap means. Firstly, because our body is electroneutral and doesn't really have a charge, our body fluids, including the plasma, will have the total anions equal to the total cations. The total anions will include, of course, both the measured anions, which are the chloride and the bicarbonate, and the unmeasured anions, which are the anions that are not usually measured in the lab, such as the phosphate, the albumin, the sulfate, and even the organic acids such as lactate. All of those anions will contribute to the total anions, whereas the measured cations are the sodium, and the unmeasured cations are usually just the potassium, the magnesium, and the calcium. So you can see here on the first drawing that the measured cation, which is only the sodium, is more than the measured anions, which are the chloride and the bicarbonate. And this difference right here between the two of them is what we are interested in, which is called the anion gap. And it's called anion gap because there is literally a gap in the anions. The measured anions are not matching the measured cations, and the reason is we are not looking at the other unmeasured anions, which are seen in the second drawing. And you can notice as well that the unmeasured anions are more than the unmeasured cations, and that makes sense to compensate for the anion gap. So the bottom line is, what I want you to understand from this drawing, that the difference between the measured cations and the measured anions is equal to the difference between the unmeasured anions and the unmeasured cations. And that's also explained by this equation. If we rearrange it, you can see that the unmeasured anions minus the unmeasured cations is equal to the measured cations minus the measured anions. And that leads us to the following two conclusions. The anion gap is equal to the measured cations minus the measured anions, and the anion gap is equal to the unmeasured anions minus the unmeasured cations, as explained by this equation. So this whole dilemma is to reach us to the following conclusion. The first equation is the one we use to calculate the anion gap, and the second equation for the anion gap is really the one we're interested in. So we calculate the first one to determine the second one. And if you ask me, why not just calculate the second one? And the reason is, it wouldn't be cost effective. It wouldn't be cost effective for the labs to measure each time for every patient all the unmeasured anions and all the unmeasured cations, because simply that would take too much time and too much money. So the trick is to know how much unmeasured anions we have using the measured ones. And of course the anion gap will have a normal range accounting for the difference between the unmeasured anions and the unmeasured cations, and the range is different from lab to lab. Now there are two general things which we're interested in the anion gap: either having a high anion gap, which is abnormal, or having a low anion gap, which is also abnormal but is also uncommon. So in order to have a high anion gap, you need to have an increase in the unmeasured anions in this equation so that the anion gap is high. But using the first equation, in order to have a high anion gap, you must have a low bicarbonate, which is indeed what happens in high anion gap metabolic acidosis. You must have a low bicarbonate in order to have a high anion gap in the first equation. And applying this high anion gap to the second equation, we must have theoretically increase in the unmeasured anions in order to have the same number of the high anion gap. And therefore an increase in any of the following will give a high anion gap, starting with hyperalbuminemia, hyperphosphatemia, anionic paraproteinemia. But actually those first three, which I have marked in white, not high anion gap metabolic acidosis, because they are not acidic. But those in yellow are the ones we're interested in for this lecture, which are also far more common to cause a high anion gap compared to those three. And those are lactic acidosis, ketoacidosis, oxalic acid from ethylene glycol ingestion, formic acid from methanol ingestion, and salicylate poisoning, and a few other examples. So any of those in the yellow will cause a high anion gap metabolic acidosis. But theoretically, however, if we have a decrease in the unmeasured cations, that will also increase the anion gap. But that doesn't really occur clinically because the potassium, the calcium, and the magnesium contribute very little to the anion gap, and therefore they have trivial effects on the anion gap. The second scenario which could occur is to have a decreased anion gap, which means a decrease in the unmeasured anions. But this is actually uncommon, and it occurs primarily with hypoalbuminemia. But it could also occur in cationic paraproteinemia, lithium intoxication, or even halide poisoning. Fantastic. Now let's move to the etiology of metabolic acidosis. And again, the etiology could be due to any of the following three mechanisms. The first is increased acid production, and the second is loss of bicarbonate, and the third is the decreased acid excretion. And you will notice that we will be discussing the different mechanisms of both high anion gap metabolic acidosis and the normal anion gap metabolic acidosis whenever any of them fits under certain pathophysiology. Great, so let's start with the increased acid production, and we have a variety of causes. The first is lactic acidosis, with lactic acidosis having two types, type A and type B. Type A is due to tissue hypoperfusion, which is basically any type of shock causing the tissue hypoperfusion and therefore shifting the glycolysis into anaerobic glycolysis and therefore producing lactate, which is the lactic acid. Or as in type B, in which the tissue perfusion is normal, but you have other mechanisms by which they generate the lactic acid, such as the severe liver disease, which fails to metabolize the lactic acid produced, and metformin, which is thought to interfere with the electron transport chain and therefore inhibit the oxidative phosphorylation, and the malignancies, which are thought to produce lactic acidosis in several mechanisms, such as dense clusters of tumor cells inducing anaerobic glycolysis, or the thiamine or riboflavin deficiency induced in certain malignancies, or even another mechanism suggested is the reduction in lactic acid excretion in malignancies. And then we have alcoholism, and alcoholism can induce lactic acidosis through two primary mechanisms. The first is by causing liver disease and therefore decreased metabolism of lactic acid, and the second is that the oxidation of ethanol will reduce the NAD to NADH ratio and therefore shifting the pyruvate into anaerobic glycolysis, in other words shifting the pyruvate towards lactate production. And finally we have the mitochondrial dysfunction, and mitochondrial dysfunction could be either inherited as seen in Melas syndrome or acquired as is seen in certain medications such as certain antiretroviral drugs, or with the use of the anesthetic propofol, or with the use of the antibiotic linezolid. And finally, we could actually include one more cause, which is HIV infection, but it has actually been explained indirectly in the previous causes, as HIV infection can cause lactic acidosis through two mechanisms. The first is by the high risk of opportunistic infections and AIDS, and therefore causing type A lactic acidosis due to septic shock, or HIV infection can cause lactic acidosis through the antiretroviral drugs which are taken to treat the HIV infection and therefore causing a type B lactic acidosis. Brilliant. Now let's move to ketoacidosis, and you'll notice that ketoacidosis is labeled in red, and that's because depending on the situation, you can have either a high anion gap or a normal anion gap metabolic acidosis in ketoacidosis. And please also note that everything written in black will cause a high anion gap metabolic acidosis, whereas those in red can cause either a high anion gap or a normal anion gap metabolic acidosis. So let's get back to ketoacidosis, and we have three types of ketoacidosis. The first is diabetic ketoacidosis, and simply in diabetic ketoacidosis you have insulin deficiency, which favors fatty acid oxidation and ketogenesis, and the second is starvation ketoacidosis, and in starvation we have prolonged fasting and hypoglycemia, which also favors ketogenesis, and the third is alcoholic ketoacidosis, And the mechanism in alcoholic ketoacidosis is primarily through the metabolism of alcohol in the liver producing keto acids, and all of them will cause high anion gap metabolic acidosis. However, once IV normal saline is given in these patients with ketoacidosis, the renal excretion of the keto acids will improve because of the increased renal perfusion. And since the keto acids are excreted in the urine as sodium and potassium salts, you will also have increased excretion of the sodium and potassium, and that will decrease the anion gap, as we recall the equation from the previous slide. And not only that, but in addition, the loss of those keto acids also means the loss of potential bicarbonate. And the reason is, when the keto acids are still in the body, they will be metabolized to regenerate the bicarbonate in a certain mechanism. But since now the keto acids are lost in the urine, this means there is no more regeneration of bicarbonate, and therefore a free loss of a potential bicarbonate. And the free losses of bicarbonate will also contribute to the normal anion gap metabolic acidosis, combined with the loss of the sodium and potassium salts. Great, now let's move to the toxins which cause metabolic acidosis, starting with methanol, which is metabolized to formic acid and therefore causing a high anion gap metabolic acidosis. We have ethylene glycol, which is metabolized to oxalic acid and glycolic acid, both of which cause high anion gap metabolic acidosis. And then we have salicylate poisoning, which is aspirin, and aspirin can cause metabolic acidosis through various mechanisms, with the most important being that aspirin causes uncoupling of the oxidative phosphorylation and inhibition of the Krebs cycle, both of which cause accumulation of various organic acids and increased production of the lactic acids and the keto acids. And another mechanism is that aspirin to some extent impairs the renal function, which causes also accumulation of the organic acids such as phosphoric acid and sulfuric acid. And now moving to chronic acetaminophen ingestion, which is thought to be due to the chronic glutathione deficiency it causes. And then we have D-lactic acidosis, which is the D-lactic acid absorbed from the intestines after the fermentation of the carbohydrates by the colonic bacteria. Now please note that this D-lactic acid is not the same as the normal human lactic acid, as the normal human lactic acid is called the L-lactic acid. And therefore, when we absorb this D-lactic acid from the intestines, it will not be metabolized by the same enzymes as we have for the L-lactic acid. And therefore, the D-lactic acid will persist in the systemic circulation for long periods of time before its removal. Now, there are certain conditions in which you have increased absorption of the D-lactic acid, such as in short bowel syndrome, or in a high carbohydrate load, or diminished colonic motility. And these patients will typically present with a high anion gap metabolic acidosis and encephalopathy. However, the D-lactic acidosis could also present as a normal anion gap metabolic acidosis, and that's because the D-lactate is not reabsorbed in the proximal tubule by the L-lactate transporter, as the proximal tubule only has the L-lactate transporter for reabsorption. And since the D-lactate will be excreted in large amounts in the urine, it will be excreted as sodium and potassium salts, and therefore this will result in a normal anion gap metabolic acidosis. And this is the reason I have marked the D-lactic acidosis in red, since it has the potential to cause any of the two types of metabolic acidosis. And then we have the toluene ingestion, and the toluene is metabolized to benzoic acid and then to hippuric acid, both of which contribute to the high anion gap metabolic acidosis. And this is what occurs, and this is what takes place early in the ingestion or when the renal function is impaired. But later in the ingestion, or when you have a good renal function, the benzoic and the hippuric acids will be excreted in the urine as sodium and potassium salts, and therefore will result in a normal anion gap metabolic acidosis. And therefore I have marked the toluene ingestion in red, representing the two possible scenarios of presentation. And then going for the second category, which is loss of bicarbonate, with the first cause being the diarrhea and the GI losses, such as the fistulas and the villus adenomas. Now these two will cause a normal anion gap metabolic acidosis due to losing eventually the bicarbonate through various mechanisms, but also in diarrhea, a more important mechanism is losing the organic acid anions as sodium and potassium salts in the GI tract. And therefore these organic acid salts will not be reabsorbed, because normally if these organic acids are reabsorbed, they will be reconverted in the body into bicarbonate, just like what happened in the kidneys before, as we have explained previously. So therefore the loss of these organic acid salts means the loss of potential bicarbonate. However, in a severe diarrhea, we could actually have a high anion gap metabolic acidosis because of various mechanisms, such as the hypovolemia-induced lactic acidosis and hyperalbuminemia, and because in severe diarrhea you will actually have hyperphosphatemia, because acidosis causes hyperphosphatemia, and if you remember from the previous slide, increased phosphate levels will increase the anion gap. And finally, in diarrhea you could also have a decreased GFR because of the hypovolemia, and this will cause a high anion gap metabolic acidosis. The second cause is RTA type 2, which is the proximal RTA, in which there is a defect in the proximal bicarbonate reabsorption, and then we have post-treatment of ketoacidosis, which we have already explained under the ketoacidosis, and finally the carbonic anhydrase inhibitors such as acetazolamide, which causes the loss of bicarbonate in the urine. Perfect. Now let's move to the third category, which is the decreased acid excretion, starting with the chronic kidney disease. And the chronic kidney disease will initially have a normal anion gap metabolic acidosis due to the decreased excretion of the hydrogen ions as titratable acid and ammonium in the kidneys, as normally the hydrogen ions will be excreted in the urine as titratable acid and ammonium, but since the GFR is reduced in the chronic kidney disease, you will have hydrogen ions retention. However, when the chronic kidney disease progresses until it reaches about the end-stage kidney disease, you will have retention of other anions such as phosphate, sulfate, urate, and hippurate, and this will raise the anion gap and give you a high anion gap metabolic acidosis. However, even in the end-stage kidney disease, some patients actually still maintain the normal anion gap, and that's because of the decreased protein diet and therefore decreased acid production, and because of the high fruit diet, because the fruits contain citrate and the citrate is converted into bicarbonate. And finally, we have the RTA types 1 and type 4, with type 1 being the distal type, in which there is inability to secrete the hydrogen ions in the collecting duct, and the type 4, which is the hyperkalemic type, in which there is decreased aldosterone action and therefore retention of both the hydrogen ions and the potassium. This is an overall review on metabolic acidosis etiology, and there are still other few causes which are not mentioned in this video. Now let's move to the management of metabolic acidosis. And in history taking, we will ask about all of the following, starting with the hypoperfusion, and this includes all the four major categories of shock, so we will screen for all of them, and then we'll ask about specifically for diarrhea, and then inquire about any toxins ingested such as the methanol and the ethylene glycol, and then inquire about any drugs ingested such as the salicylates and metformin, and then ask the patient about the past medical history, about any diabetes mellitus or renal disease, and finally ask about the history of alcoholism. And then we move to the physical examination, and most importantly we first assess the vital signs, which are very important, specifically the respiratory rate, and that's to know if there's any ongoing respiratory compensation, and of course the blood pressure and the heart rate, and that's to assess for any dehydration or hypovolemia. And then we examine for other signs of dehydration such as altered mental status and decreased urine output, and then if we look for fruity breath, which could indicate a DKA, a diabetic ketoacidosis, and finally examine the patient for any obvious malnutrition signs. So this is pretty much for the physical examination. And then we move to the investigations, and we start with the metabolic profile, specifically for the potassium levels and the sodium levels, and then we calculate the serum anion gap using the following formula, which helps us differentiate, is this a normal anion gap metabolic acidosis or a high anion gap metabolic acidosis. And then we calculate for another anion gap called the urine anion gap, which is using the following urinary electrolytes, and that's particularly helpful because if the urine anion gap is positive, that would indicate a urinary cause for metabolic acidosis, whereas if the urinary anion gap is negative, that would indicate an extrarenal cause for the metabolic acidosis. And then we look for the glucose level to look for NDKA, we assess the GFR to look for any kidney disease or dysfunction, and finally we order for the most important one, which is the ABG, looking for the blood pH, the PaCO2, and the serum bicarbonate, all of which are very important in categorizing your differentials. However, we will be discussing the approach to the acid-base disturbances in a future video, and that's because all of the acid-base disturbances are more or less correlated. And finally, we move to the treatment of the metabolic acidosis, with the most important being treating the underlying cause, because metabolic acidosis is a sign of a disease and not a disease itself. So if the patient has an underlying DKA, we give insulin. If the patient has hypoperfusion, which is the type A lactic acidosis, we reperfuse the patient either by fluids or pressors, depending on the underlying cause. If the patient has methanol or ethylene glycol poisoning, then we will best go for dialysis, and so forth. And if there is a coexisting potassium disorder, then we must correct that potassium disorder, especially if we are going to give a sodium bicarbonate, which is considered if the serum bicarbonate is less than 8 millimoles per liter. And that's because when the sodium bicarbonate is given, it will give a sudden increase in the pH, and therefore that will shift the potassium into the cells, which could give a potential hypokalemia, especially if there was a potassium deficit in the first place. Another risk of giving sodium bicarbonate is volume overload because of the sodium given with the bicarbonate. Another alternative to sodium bicarbonate is called tromethamine, which has the advantage of not having a sodium, and therefore there's no risk of volume overload. This is all in summary for metabolic acidosis. I really hope you have enjoyed this video. Please feel free to post any comments or questions, and I wish you a great day.